Let's start ENT. So in ENT, we will start from nose, then pharynx, then ear, then larynx. Okay, this is the sequence we will follow. Okay, so from the nose, so to in any disease in medical science, to understand any organ, you have to first understand the anatomy of that organ, then diseases related to it, blood supply of that organ, nerve supply, है ना, tumor of nose. So every organ has like we will study. Let's talk about liver. So in liver, we will first learn about the anatomy. Then we will learn about the physiology. Then we will learn about the blood supply. Then nerve supply. Then the diseases of liver. Then tumor of liver. So this is the sequence to learn any diseases. Okay, learn any organ. Okay. So let's first talk about the nose. So in nose, we will learn anatomy and diseases related to the anatomy if disturbed. Diseases of nose, any organ, body in organ, you will find infection. So infection could be bacterial, viral or fungal. Okay, so we will learn about the infection in nose and other diseases. Then we will learn about the blood supply of nose and the disease related to it, blood supply disruption. Next, we will learn about the nerve supply of nose. Okay, tumor of nose. Okay, in every organ you will find the tumor. Okay, now diseases related to the anatomy. So first is conal atresia. So what is conal atresia? It is persistent of buccal membrane. Let's assume this is nose, this is nose, this is mouth. Okay, so you have find that air is, this is mouth and this is nose. Okay, this is mouth, this is nose. So air is going through these nostril and it goes into the pharynx, then to the larynx. Okay, this is the pathway of air. Now there is a membrane which is present here at the time of in the fetus. This is buccal membrane. So buccal membrane is present in the fetus, but during the time of birth, it atrophied. This is at the time of birth, this is involute. Okay, this is not present at the time of birth. Okay, but in some cases in conal atresia it is persist. So it could be unilateral persisting or it could be bilateral persisting, because nostril are two. So it could be unilateral, there is only one buccal membrane present, persistence of one buccal membrane, or there could be chances that both side buccal membrane is persist. So if it is persist both side, then patient will have dyspnea, patient will in distress because he is not able to breathe. Okay, so and this buccal membrane could be membranous, could be bony, or could be mixed, membranous or bony. Okay, and this obstruction could be incomplete or complete. Incomplete is half obstruction, only half obstruction, and could be complete entire obstruction of the nasal pathway. Okay, so there are many types, okay, of conal atresia. You can see in this patient, so this is nasal pathway, so this is normal patient. You can see there is a persistent of buccal membrane. Okay, nasal air is blocked. Okay, so what are the risk factor? What are the risk factor if mother is taking methimazole? Okay, so this is the this leads to conal atresia. Now management, so management by McGovern technique. So what is McGovern technique? It is mouth breathing. You can see in this patient, this is inserted in the mouth of patient. So his mouth is opened and patient is doing mouth breathing. Okay, next is endoscopic excision. So you will insert an endoscope. Endoscope is like a camera. So if you will insert the endoscope and cut this membrane. So this is endoscopic excision, and you will apply mitomycin. So mitomycin will prevent to regenerate again. Okay, it is associated with CHARS syndrome. So what is CHARS syndrome? C is for coloboma, H is for heart defect, A is for conal atresia, R is for retarded growth. Okay, and genitourinary defect, G is for ear abnormality. Okay, so this is the conal atresia. This is disease related to anatomy of distorted anatomy. Okay, now you have two term, encephalocele and glioma. So what is the difference between encephalocele and glioma? So you can see this is the patient will present like this. You can see this kid both eyes and there is a swelling present. So you will confuse that it could be glioma or it could be it could be glioma or it could be encephalocele. So how will you identify it? So in encephalocele, swelling is compressible and it has connected to the brain, so intracranial connection is present. Okay, and in nasal glioma, it is firm and non-compressible, it is no any connection is present, so it is nasal glioma. Okay, because encephalocele name in itself written, it is connected to brain, so if it is connected to brain, the swelling is compressible. And nasal glioma, there is no any connection to the brain, it is originate from the nose. Okay, now we have learned about the anatomy, distorted anatomy, है ना? Now let's talk about the anatomy of external nose. So you can touch the upper one third of nose, you can touch, it is bony. Lower two third is cartilaginous. Okay, now the nasion, so you can see this is nasion, it is bony junction. Then rhinion is bony and cartilaginous junction. So bony is present. Lyman nasi, so what is Lyman nasi? So Lyman nasi is ridge or line which is present on inner aspect of nose, okay, which separate vestibule of nose from the rest of cavity. This is vestibule and this is rest of cavity. So this is rest of cavity is separated by the vestibule by Lyman nasi. Okay, now there are 4 type of cartilage. So 4 type of cartilage present. So first is upper lateral cartilage, these are the upper lateral cartilage. This is lower lateral cartilage, these are the sesamoid cartilage. And this is the quadrilateral cartilage. So this is the nose. Okay, so these are present on the, you can see this patient, you can see this is the upper lateral cartilage, this is lower lateral, these are the sesamoid cartilage, and this is in between is quadrilateral cartilage. So you can see quadrilateral cartilage is unilateral, septal is unpaired septal cartilage. Okay, and other three are paired. You can see these are the upper lateral, these are lower lateral, these are sesamoid. Okay, now internal nasal wall. So what is internal nasal wall? So you can see this is internal nasal wall, it is the narrowest part. You can see medial wall is formed by the nasal septum, lateral wall is formed by the inferior turbinate, and floor inferior is formed by the floor of nose. Okay, this is internal nasal wall. Okay, so what is Cottle test? So Cottle test is done, you can see if we are doing Cottle test on right side, so it will improve the airflow. So this is positive Cottle test. Positive Cottle test denotes that it is the nasal wall collapse. Obviously if you do this, then obviously airflow improve obviously. Okay, now deformity of nose, obviously this is the disturbance in anatomy. So you can see this is crooked nose. So in crooked nose, nasal root and tip is in midline. So this is crooked nose, you can see this is crooked nose, nasal tip, root and tip is in midline. So this is crooked nose, deviated nose, tip and dorsum deviated to one side. So if tip and dorsum is deviated to one side, that is deviated nose. Then saddle nose, so saddle nose is depression in dorsum. So you can see this is depression in dorsum, so that is saddle nose. Okay, so how will you manage this patient? By doing the rhinoplasty. Saddle nose is treated by rhinoplasty. Next is rhinophyma. So what is rhinophyma? Rhinophyma is hypertrophy of sebaceous gland. You can see this is rhinophyma. You can see this is rhinophyma. This is hypertrophy of sebaceous gland. It is associated with acne rosacea. Okay, it is associated with acne rosacea. Okay, so we have understood about this. Now anatomy of lateral wall. So anatomy of lateral wall. So anatomy of lateral wall has 3 turbinates. First is inferior turbinate. So inferior turbinate is longest. This is inferior turbinate. So we have learned about the medial wall. Now we are studying about the lateral wall of nostril, lateral wall of nose. So this is inferior turbinate, this is middle turbinate, and this is superior turbinate. So inferior turbinate is all along the lateral wall, middle turbinate is 1/2 along the lateral wall, and superior turbinate is 1/3 of the entire lateral wall. Okay, now what is meatus? So meatus is lateral to the turbinate, meatus is lateral to the turbinate. Okay, okay, and one more thing. So if there is infection, you can see this image, this is frontal lobe and this is nose. So this is the area. If there is infection in this area, this infection can go to the brain, because why? Cribriform plate. So it is also known as dangerous area. Okay, point, this is lined, nose is lined by ciliated columnar epithelium. Because of cilia, so there is fluid inside it. Okay. Now we have learned about the three turbinates and three meatus. Okay. Now there are different opening in different meatus. So in inferior meatus, there is opening at anterior 1/3 and posterior 2/3. So this is inferior turbinate. And in inferior meatus, there is opening at anterior 1/3 and posterior 2/3. So this opening is of nasolacrimal duct. So nasolacrimal duct, name in itself written, it's starting from the lacrimal gland and connected to the nose. So it is starting from the lacrimal gland and connected to nose, and direction is downward, backward, and laterally. Okay. So if it got obstructed, so you have to do Krigler massage in this direction. Okay. So this is the content of inferior meatus. So now let's talk about the middle meatus. So middle meatus has content MAF. So what is MAF? It has opening of maxillary sinus. It has opening of anterior ethmoidal sinus. It has opening of frontal sinus. So we have not talked about the paranasal sinus till now. So we have maxillary sinus, and frontal sinus, sphenoid sinus, ethmoid sinus. So these are paranasal sinus. So what they did, they decrease the weight of bone. They help in phonation of voice. Okay. So we have learned about the opening. So we have learned that in middle meatus there is three opening: maxillary sinus, anterior ethmoid, and frontal sinus. Okay. Now let's talk about the superior meatus. So superior meatus has opening of posterior ethmoid sinus. So we have only four sinus: sphenoid, maxillary, and frontal, and ethmoid. So ethmoid has two parts, anterior and in superior meatus there is opening of posterior ethmoidal sinus, and it has opening of MAF. What is MAF? Medial maxillary sinus, anterior ethmoidal sinus, and frontal sinus. And inferior meatus has opening of nasolacrimal duct. Okay. Now one more thing, that this terminates, these terminate can be air filled. So it is concha bullosa. If it is hypertrophied, so it has mulberry appearance. So क्या हो सकते हैं? It could be air filled. Air filled is concha bullosa. If it is hypertrophied, it has mulberry appearance. Okay. If it is mulberry appearance, you can see. If it is mulberry appearance, then you have to do partial turbinectomy. Okay. So now we have learned about the anatomy of lateral wall. Let's talk about the anatomy of septum. So in septum, you can see this is the septal cartilage. This is quadrangular cartilage. And the bone behind it is Boehmer bone. Boehmer bone is behind to it. And there's perpendicular plate of ethmoid. Okay, this is perpendicular plate of ethmoid. Now, so you can touch the septum. The in front part, you can see there is a cartilage, and behind it, that is Boehmer bone. Okay, so in nose, if you forget anything, you can touch the nose and you can recall everything. Okay. Now quadrilateral cartilage. So this is the normal if it is a center. Now in 80% cases it is deviated. So you can see this is deviated nasal septum. This septum is deviated. So because it is deviated, so it caused the blocking of nostril at that side. So blocking of nostril and accumulation of fluid, blocking of nose. This leads to infection in nose, and sinus is near to the nose. Maxillary sinus is near to the nose. So infection from nose can go into the sinus. So it could also lead to sinusitis, recurrent sinusitis. Okay. And headache and hyposmia, hypertrophy of terminates. Why? Because this, are you getting a point? This is obstructing the nostril. This is obstructing one nostril. So because this is obstructing one nostril, so there is accumulation of fluid. Which accumulation of fluid leads to infection, and it leads to sinusitis, recurrent epistaxis. Epistaxis is blood coming from the nose, that is epistaxis. Okay, it decreases the drainage, so patient will have headache, hypertrophy of turbinates. Now the test. So what is cold spatula test? So in cold spatula test, you can see you have to place the cold spatula in front of the nose and compare the fogging. So in normal patient, spatula fogs up on the affected side. Okay, in blocked nose, there is little or no fogging seen on that side. Okay, are you getting a point? So in the affected side, there is no fogging seen because it is a blocked nose, and on the normal side, so spatula fog up on the affected side, spatula fog up on the normal side. Okay, now management. So management is by septoplasty or submucosal resection. So in septoplasty, you can see this is septoplasty. So it is a conservative procedure, and submucosal resection, it is used earlier. So it is a destructive post procedure. Septoplasty you can do at any age, ideal for anterior deviator. Okay, and submucosal resection is ideal for posterior deviation. Rear incision is used in septoplasty and clear incision is used in SMR. SMR is not used nowadays. You can see this is septoplasty. Okay, I'm not going in detail for septoplasty and SMR. Just you have to remember that septoplasty is better than SMR, and septoplasty is done nowadays. SMR is obsolete procedure. Next is septal hematoma. So septal hematoma, you can see this is collection of blood, collection of hematoma in the septum. So how could this hematoma can be collected? So if you hit someone nose, septum, so that leads to fracture of septum, that leads to extravasation of blood. So blood supply disrupted of perichondrium because of a fracture hematoma. So this leads to necrosis. Okay, so what is the treatment? Because blood is accumulated, so it will not get absorbed. So what you have to do? You have to do incision and drainage within 72 hours. If you will not do incision and drainage, then it leads to saddling of nose. Okay, next is nasal septal perforation. So septal perforation, it could be due to trauma. Obviously, if you hit someone, it could lead to septal perforation. Syphilis, tumor, these can also lead to septal perforation. Obviously, syphilis is a destructive disease. Okay, tumor could lead to septal perforation. Now foreign body. So what is foreign body? So obviously kids, not seen in adults, kids used to insert anything in their nose, in their mouth. They have tendency to put anything in their nose. Okay, so that leads to foul smelling on that side. So if it is the most common cause of unilateral foul smelling, foreign body is the most common cause. So how will you treat this patient? By doing urgent removal. Okay, you have to remove that foreign body. Okay, nasal myiasis. So what is nasal myiasis? These are the maggots in nose. Okay, maggots in nose. So that is known as nasal myiasis. So how will you treat? By turpentine oil and chloroform water, because these turpentine water, oil and chloroform water kills the maggots. Okay, next is dangerous area of face. So you can see this is dangerous area. Why it is dangerous area? Because if you hit at this place, here is cavernous sinus. So cavernous sinus is connected to brain. Cavernous sinus is connected to the other sinus. So infection at this area could get into the brain by cavernous sinus. Okay. Now nerve supply. So nerve supply of nose. Nerve supply is by ophthalmic nerve, maxillary nerve. Okay. We have ophthalmic or maxillary nerve for sensation of nose, and olfactory nerve for olfaction. Okay, Vedian nerve for secretion. There is so much secretion of cilia from the cilia in nose, that is from the Vedian nerve, which is a parasympathetic supply. Okay, so we have, आपको नाक से सूंघना है, that is olfaction, and छूने का पता चलेगा, that is sensation from ophthalmic and maxillary nerve. Vedian is for secretion. Now disorder of smell. So disorder of smell is, decreased smell is hyposmia, it is decreased smell. Anosmia is complete loss of smell. Okay, anosmia क्या होता है? Complete loss. Parosmia, perversion of smell. So what is perversion? Distorted sense of smell, where normal, odor, smell unpleasant, foul, or different from what they should. Okay, so this is parosmia. So next is sniff test. So sniff test is patient asked to smell the known fragrance. Okay, so patient is asked to smell the known fragrance, that is sniff test. Now next is endoscopy. So what is endoscopy? So endoscope is a camera. Endoscope is camera which is inserted in nose, and you can see the structure in nose. So first pass will help in visualizing inferior meatus, then second pass goes till the corona, then third pass for middle meatal area. Okay, next is spinopalatine fossa. So what is spinopalatine fossa? So this is nose, this is septum. Okay, these are the paranasal sinus. These are the paranasal sinus. Okay, now behind the paranasal, this is the maxillary sinus, which is a paranasal sinus. So maxillary sinus posterior wall. Okay, so spinopalatine fossa is present here. You are seeing from front. This is front view. This is anterior. Okay, this is nose. This is anterior view. This is posterior. So this is maxillary sinus. So paranasal sinus is somewhere here. Spinopalatine fossa is somewhere here because anterior wall is formed by the posterior wall of maxillary sinus. Posterior wall of maxillary sinus forming the anterior wall. Okay, medial wall is formed by the lateral wall of nose, and lateral wall is formed by the pterygomaxillary fissure. Okay, and posterior wall is formed by the pterygoid plate. So this is pterygopalatine fossa. So you can see this here is spinopalatine foramen or spinopalatine fossa. So you can see this is the maxillary sinus. So this is forming the anterior wall of spinopalatine fossa, and you can see this is the lateral wall. Lateral wall is formed by the medial wall is formed by the lateral wall of nose, and lateral wall is formed by the pterygomaxillary fissure. Okay, and posterior wall formed by the pterygoid plate. Okay, so this is the pterygopalatine fossa, or you can see this is the space. Okay, you have to imagine it. It is in 3D. Okay, so what is the content? Content is MMS. MMS is maxillary artery, maxillary nerve, and spinopalatine ganglion. So two nerve is supplying for sensation, ophthalmic and maxillary. So ophthalmic branch is nasociliary, which is branch to anterethmoidal, which supply the external nose and internal nose. Maxillary nerve is a branch of trigeminal. Okay, now autonomic supply of nose, which is for secretion. So greater superficial petrosal nerve, GSPN, which relies on the spinopalatine ganglion and which release the median nerve, which is responsible for parasympathetic supply for secretion in nose. Okay, now we have learned about the nerve supply of nose. Now in nose there could be infection. So infection, first is infectious rhinitis. So infectious rhinitis, most common cause is viral cause. It is not bacterial. Viral cause, that is common cold. Rhinovirus is the culprit. So because it is viral infection, so you have to give symptomatic treatment. Okay, non-infectious. So non-infectious is allergic. So IgE mediated reaction leads to allergic rhinitis. So you have to understand, in allergic rhinitis you will find pale mucosa. Allergic signers, Denny Morgan's line. You can see these are the Denny Morgan's line. This is Denny Morgan's line. Allergic salute. This is patient is doing allergic salute. Okay. So how will you treat this patient? By giving anti-allergics, by giving steroid, because steroids help in anti-inflammatory. Okay, and nasal spray. These are IgE mediated reaction. Okay. Now next is vasomotor rhinitis. So what is vasomotor rhinitis? It is non-infectious perianal rhinitis. So you can see this patient, this is normal mucosa, and this is hypertrophic rhinitis. So vasomotor rhinitis is the non-infectious perianal rhinitis, congested mucosa you will find. So how will you treat by this patient? By giving a steroid spray. and it is due to overactive parasympathetic supply which leads to vasomotor rhinitis. Okay, so vasomotor rhinitis basically is due to overactive parasympathetic supply. Next is rhinitis medicamentosa. So what is rhinitis medicamentosa? It is due to nasal decongestant overuse. So because nasal decongestant overuse, so vasoconstriction. So vasoconstriction decreases the blood supply, which leads to rebound vaso severe nasal obstruction. Okay, and how will you treat this patient? By giving a steroid. So next is hypertrophic rhinitis. So hypertrophic rhinitis, it is due to any cause. It could be due to allergic rhinitis, it could be due to vasomotor rhinitis, increase in parasympathetic supply which leads to hypertrophy of mucosa. So it causes the hypertrophic rhinitis. Okay, most common site is inferior turbinate. So if it is hypertrophied, so what you have to do? You have to resect the inferior turbinate. Next is rhinitis sicca. So what is rhinitis sicca? It is exposed to the hot dry hair which leads to crusting in anterior one third. Okay, so that is rhinitis sicca. Next is concha bullosa. So I have already explained to you. It is the air-filled cavity. It is pneumatized turbinate. Okay, middle turbinate is the most common. Mostly seen in middle turbinate. And how will you manage this patient? By doing resection. So you will find a concha bullosa bulla-like picture in the middle turbinate. Okay. Next is arterial supply. So this is nose. Okay, this is supplied by. This is mouth. This is mouth. This is nose. So it is supplied by 4 vessels: sphenopalatine artery, okay, superior labial artery, anterior ethmoidal artery, and greater palatine artery. So you can see all 4 arteries. You can see superior labial artery, okay, you can see sphenopalatine artery, you can see anterior ethmoidal artery and posterior ethmoidal artery. Okay, so you have to understand anterior ethmoidal artery is a branch of internal carotid, and other 3, greater palatine, sphenopalatine, superior labial, these 3 are branch of external carotid. Okay, now epistaxis. So epistaxis is blood from the nose. So what is the cause of blood from the nose? So most common cause for epistaxis is sphenopalatine artery. So if someone has epistaxis, so you can blindly see that it is sphenopalatine artery which is causing the epistaxis. Okay, now there are type of epistaxis: anterior and posterior. So anterior to the maxillary antrum is anterior epistaxis, posterior to the maxillary antrum is posterior epistaxis. Now venous epistaxis. So you can see this is posterior epistaxis is caused by the Budrow plexus. You can see this is Budrow plexus. It is present at the posterior end of inferior turbinate. Okay, and if epistaxis could be from the arterial. So if it is from the arterial, then it is sphenopalatine artery. If it is from the venous blood, then it is from the in anterior epistaxis. It is retrocolumnar vein. If it is posterior epistaxis, then Budrow plexus. Okay. So what is the cause of epistaxis? So cause is idiopathic in adults. In children, it is nose picking. Nose pick karte hain children. That leads to epistaxis. Okay. Now, recurrent epistaxis seen in angiofibroma, juvenile angiofibroma, it is the most common cause for recurrent epistaxis. So how will you treat the patient of epistaxis? First, by doing the Trotter method. So you can see this is the Trotter method. Patient is sitting and lean forward and slightly. So that is Trotter method. If it is not relieved, then you have to do cauterization by silver nitrate. If it is still continue, then anterior nasal packing. If it is still continue, then posterior nasal packing. So nasal packing is the nose is packed. Nose is packed. That is anterior nasal packing. If it is not, if it is still continue, then posterior nasal packing. Okay. Then if it is still not, after posterior nasal packing, if it still continues the bleeding, then you have to do TESPAL. What is TESPAL? Transendo nasal sphenopalatine artery ligation. Okay, so first you have to do sphenopalatine artery ligation. If it is still not relieved, if it is still bleeding, then you have to do for maxillary ligation, but never do ligation of internal carotid artery. After maxillary, you can ligate the external carotid, but never the internal carotid. Okay, next is Now, hereditary hemorrhagic telangiectasia, it is autosomal dominant disorder. You will find multiple telangiectasia, okay, greater than 18 episode of epistaxis in a month, okay. Next is paranasal sinus. So we have already learned that there are 4 types of paranasal sinus. You can see this is maxillary sinus, you can see this is ethmoid sinus, frontal sinus, and sphenoid sinus is behind, okay. And because maxillary sinus is big, so it is most likely to get infected because it is near to the nose, and sphenoid is far uh, far from the nose, so it is less likely to get infected, okay. Now it is lined by the pseudostratified. So how will you remember? Nose is lined by the ciliated columnar and PNS. So P क्या है? Paranasal है, तो pseudostratified columnar epithelium, okay. Sphenoid is posterior. Function: resonance to the voice, lighting of skull, I have already explained to you. Ventilation of sinus, okay. Maxillary sinus is largest, present at birth because it is largest, so you can remember by this way that it is present from the birth. Most common cause I have already explained to you, because it is present at the level of cheek. You can see it is present at the level of cheek, so patient will have tenderness over the cheeks, okay. Ethmoid sinus, it is also present at birth, so math maxillary and ethmoid, these two are present at birth, okay. So ethmoid sinusitis, so you can see ethmoid is near to the eye, you can see ethmoid is near to the eye, so ethmoid sinusitis leads to eye movement affected, and it is most common sinusitis in children. Most common sinusitis in adult is maxillary, but in case of children it is the most common sinusitis, okay. One or two more features: anti-ethmoidal cell, bulla ethmoidalis, it is the biggest and most prominent cell. So an ethmoid sinus have various so many paranasal sinus, okay. Anti-ethmoidal cell is the biggest cell, okay. Infraorbital halar cell, it is extensively pneumatized cell, it is forming the floor agarnaceae. So you can remember that it is A. So entermost ethmoidal cell, posteriormost ethmoidal cell open in the superior meatus. We have already know posterior ethmoidal sinus open in the superior meatus. Onady cell, it's near to the sphenoid. So O is in sphenoid and O is in onody cell. Sphenoid sinus, it is least common sinusitis. I have already explained to you. Frontal sinus not present at birth, okay. So patient will have early morning headache, office headache, sinus tenderness, okay. These are all are the feature of frontal sinusitis. Now acute sinusitis, it is the most common route of infection. Most common route of infection in sinus is from the nose, obviously, because nose is near. So if it is an infection in nose, so that leads to infection in sinus also, that leads to sinusitis. Most common cause is viral. Clinical features: patient will present with nasal discharge, okay. Next is bacterial, acute bacterial sinusitis caused by the streptococcus. Patient will present with nasal discharge, facial pain, double sickening, okay, because you can see this is active, you can see this is nose and this is maxillary sinus, so mucus is filled with maxillary sinus. So how will you treat the patient? By giving, because it is infection, so you have to give antibiotics, you have to give decongestant, saline, nasal spray. If greater than 3 months of infection, then it leads to chronic sinusitis. Staph aureus is the cause. Risk factor in immunocompromised patient, obviously the patient is immunocompromised, so it leads to chronic sinusitis. Best investigation is NCCT head, okay. Treatment is antibiotics, okay. Steroid nasal spray. If there is no relief, then FESS. What is FESS? Functional endoscopic sinus surgery, okay. Keldwick-Leuch operation, it is obsolete, it is not done now. Infraorbital nerve injury, Keldwick-Leuch operation leads to infraorbital nerve injury. Now we have done with, we are doing the functional endoscopic sinus surgery. So next is complication of sinusitis. So what are the complication of sinusitis? So you can see this is nose, this is maxillary sinus, and these are, you can see, ethmoid sinus. So you can see orbit is near to the nose, so infection from ethmoid wound can reach to the orbit, so it leads to orbital cellulitis, okay. And you will find there is a orbital apex is there, there is a superior orbital fissure is there, okay. So in orbital apex, 2nd, 3rd, 4th, 5th and 6th nerve is involved, okay. In superior orbital, 3rd, 4th, 5th and 6th nerve is involved. So we have read in about these terms in anatomy also, okay. Next is cavernous sinus thrombosis. So what is cavernous sinus thrombosis? It involves first the sixth nerve, then third nerve, then fourth nerve. Okay, so this is the sequence. The nerve affected in cavernous sinus thrombosis. These are all complication of sinusitis. Okay, it can also affect the frontal bone. It can affect the frontal bone. So frontal bone osteomyelitis is known as Pott-Puffy tumor. So this is also seen Pott-Puffy tumor. Okay. Now chronic complication. So it can form the pilocele and myocele. Okay. So these all are complication of sinusitis. Next is different views of X-ray. So first is occipitomental view. So you can see this is occipitomental view. This is mentum. This is occipit. So the X-ray radiation goes in this line. So there is only occipitomental view. So maxillary sinus is visible because the X-ray line is going on through the maxillary sinus. So occipitomental view is used for maxillary sinus. Okay. If you, it is also known as Waters view. Next is occipitofrontal view. You can see this picture. This is occipitofrontal view. This is occipit, and this is frontal. So X-ray rose is going this way. So this is occipitofrontal view. Okay. Next is Spire view. So what is Spire view? Waters view with mouth open. So it used for sphenoid sinus. Okay. Next is fungal sinusitis. So fungal sinusitis first is non-invasive. So non-invasive is fungal walls, fungus entrapped in sinus. Maxillary sinus is most commonly affected. Okay. Management by functional endoscopic sinus surgery. So what is this? So you know we have endoscope. So endoscope is like a camera which is going inside the nose. So this is used in removing the fungus, functional endoscopic sinus surgery. Okay. Next is allergic fungal sinusitis. So it is commonly seen in ethmoid sinus. Ethmoid sinus is mostly due to sinusitis is mostly due to allergy. Now invasive. So invasive, you know, if the fungus is invading, it means we have the patient has low immunity. That's why it is invading. Okay. So this is invasive fungal sinusitis. It is seen in immunocompromised patient. So because it is the highly destructive fungus, so we will give liposomal amphotericin B. Okay. Next is chronic rhinosinusitis. Nasal polyp. So nasal polyp is formed due to chronic rhinosinusitis. So what is polyp? Polyp is outpouching from the mucus. You can see there are two types of polyp. Multiple polyp you can see in ethmoid, and enteroconal polyp. It is unilateral. It is originate from the maxillary sinus. Okay. So it is edema of middle meatus, narrowing of area, increase the velocity of air, and negative pressure, which leads to formation of polyp. Bilateral nasal polyp. It is because of the allergy. Most common cause. Okay. Next is Schemter triad. So Schemter triad is seen in Schemter triad as Na. What is Na? Nasal polyp, aspirin hypersensitivity, and asthma. So these all are the three components of Schemter triad. Cystic fibrosis. It is a disease which leads to decrease in mucociliary clearance. So decrease in mucociliary clearance. It's seen in children. Most common cause for bilateral polyp. Unilateral polyp we have already discussed, that is enteroconal polyp. It is obstruction of maxillary sinus which leads to formation of polyp. Blockage of cona, nasal obstruction, because unilateral polyp originate from the maxillary sinus and blocking the cona. Okay. Management by antibiotics and surgically by excision of polyp. You can excise the polyp. Okay. And we have already discussed that ethmoid polyp has multiple polyp, and bilateral it is associated with allergy. Okay. So we have discussed about ethmoidal polyp, which is bilateral and it is associated with allergy. You can see this. And enteroconal polyp is unilateral. It is obstructing the cona. And okay. Next is atrophic rhinitis. So atrophic rhinitis due to atrophy of nasal mucosa. It is due to Klebsiella pyogenes. It causes merciful anosmia. And how will you treat this patient? By removing the crust. Okay. Treatment by nasal douching. Are you getting the point? This is the infection which is caused by the Klebsiella pyogenes. And the patient will present with merciful anosmia. And how will you treat this patient? By doing the nasal douching. It contains sodium chloride, sodium biborate, and sodium bicarbonate in the ratio 2:1:1. Okay. And how will you treat? By giving chemicetine. So chemicetine has component PCOD. That's it. PCOD मतलब क्या होता है? Propylene glycol, chloramphenicol, estriadol, and vitamin D. And management surgery is modified young operation. Next is rhinosporidiosis. So rhinosporidiosis is caused by the Rhinosporidium seabri. It is a protozoa. You can see this is the histology of rhinosporidiosis. You can see this is the respiratory epithelium. These are various sporangia. Okay, these are various sporangios. Okay, it is the inflammatory cell composed of lymphocyte, plasma cell. You can see this is the this is the sporangios. Okay, it is a red vascular mass with sporangia protozoa. So how patient communicate this disease? From the history of bathing in pond. So because this is vascular, so patient will have epistaxis. So basically we are studying the infection. We have studied the infection from bacteria, infection from fungus. Now we are studying the infection from protozoa in nose. Okay. So sporangia is filled with sporozoa and management by wide excision, removing all these protozoa, then cauterization of base and dapsone sulfonamide given. Next is rhinoscleroma. So rhinoscleroma is caused by the Klebsiella rhinoscleromatis. You can see this is the Meckel cells, Russell bodies. You can see. So Meckel cells are the large foamy histiocytes. Okay. At tropic stage, granulomatous cicatricial stage, management by ciprofloxacin. Okay. Sarcoidosis. Sarcoidosis patient has a strawberry nose. Fracture of bone, fracture of face. Nose is the most commonly bone fracture. You can see this is the Chevalier. This is the Jargive. It is horizontal, it is vertical. Okay. And how will you treat this patient? By doing close reduction. You will not directly go for operative fixation. You will reduce it closely and will take the help of maxillofacial surgeon. Okay. Now the Le Fort fracture. So this is skull. This is skull. So in Le Fort fracture, it involves this area. Type 1. In type 2, it involves this. And in type 3, it involves this. Okay. So there are 3 types of Le Fort fracture. CSF rhinorrhea. What is CSF rhinorrhea? CFS is leaking. CFS is leaking from nose. So you will find this halo sign. If you take out that fluid which is coming out from the nose and put on the and you will see then there is a target sign you will find. It is the common cause because of trauma. Handkerchief test. There is no any stiffening. If you put that fluid which is coming out from the nose on the handkerchief, there is no any stiffening seen. Okay. Beta transferrin, it is the best biochemical marker you will find in that fluid. Okay. Now the tumor of nose, inverted papilloma, it is the most common benign tumor which is associated with HPV virus. Osteoma, it is the most common benign tumor of paranasal sinus. Okay. Basal cell carcinoma. So basal cell carcinoma is rodent ulcer. It is seen in elderly males. Squamous cell carcinoma, it is the most common carcinoma of nasal cavity. So these all are facts you have to mug up. Olfactory neuroblastoma, it is originate from the olfactory epithelium. Okay.